We now move on to the next talk by Dr. Krishnaprasad. There is a small change in his topic. He is going to speak about how not to miss glaucoma in a busy OPD. Over to you, Dr. K.
So I thank KSOS and all my friends here for the inclusion. And so there are some pearls that I would like to share that like in the form of 10 commandments. So I think a busy person always finds time, and a busy OPD is not an excuse for incomplete examination and missing the diagnosis, especially with respect to glaucoma. So if your eyes are open, you probably don't need much time to probably pick up a case and probably further go about it. So you need to have that pattern recognition. There are some cases which come with a particular pattern. There is some way of presentation, and you should actually have your eyes open for it. So the most important thing is the history. Like as postgraduates always tell, there are certain vague histories, even though it's not very common in practice, but there are, especially ACGs, do have some vague history of intermittent blurring, frequent change of glasses. Family history is very important. Probably this is what we miss. If you probably start screening the family members of all our own patients that we have, probably you will have a higher case finding, and that is what probably is something very important. And what is very important, my postgraduates, the one eye is already having a totally opacified cornea, maybe something like an atrophic bulb eye. They don't really bother about that eye. They just write atrophic bulb eye and start looking at it. If you really ask what happened to that eye, maybe that patient had glaucoma and absolute glaucoma, probably then finally it went into an atrophic changes. So the very fact that there was some history of glaucoma in that eye itself can make the balance to swing more towards diagnosing a glaucoma in the seeing eye. So that's probably very, very important. See, if you have hyperopia, which is a obvious risk factor, moderate to high myopias are risk factors for POEG, like hyperopia for ACG, and very importantly, post-refractive surgery. Many a times, people may not come out with the history of that they had undergone a PRK or a LASIK in the past, when they, after 10, 15, 20 years. So they will have very thin corneas, and you may probably be missing a lot of early glaucomas. And these are the patients who actually are risk factors for glaucoma. Myopics develop POEG more than others, and these are the patients where we can actually miss them for a long time. And very importantly, pediatric aphakias and pseudophakias. This was very common earlier when the surgical techniques were not very well evolved. When you actually have a cataract, it also means that there is some maldevelopment of the eye. It is not just the lens. There is some problem with the outflow facility of the aqueous channels. So there's a possibility that it may be a latecomer. You have to check the NCT or the non-contact tonometry, if possible the IOP of every child, aphakic or pseudophakic, coming to you for a regular follow-up, even though there are no symptoms attributing to that. And probably in India, we need to worry about ACG, which is almost half of the cases that we see. Why we don't see so often is probably we miss it. Especially if you have that typical iris atrophy or iris orling, which is the telltale sign of a previous ischemic problem of the iris, and Van Herrick shallow ACs, if you probably go ahead with them, you will be probably able to pick up. And in India, we have a lot of PXF. If you have even a very minimal evidence of PXF, you should actually be very wary of it, because PXF glaucomas progress fast, their IOPs fluctuate too widely, and they have progression of blindness very fast compared to the other POEG. This form of secondary glaucoma, secondary OAG, is extremely dangerous in India. And if you have the PXF in the other eye, which is now probably absolute, and if you don't find PXF in the seeing eye, still you should be wary of it, and you should actually be doing. You have to run a diurnal variation, because at presentation or in the office hours that you see, he may have normal pressures. And whenever you operate a case of cataract in a PXF with a normal IOP, always expect an IOP spike. In worst cases, you may actually decompensate that PXF glaucoma into an absolute clinical glaucoma. And routinely, should you check the intraocular pressure in all patients, and what is the age cutoff? So normally, you can just do a non-contact tonometry or a rebound tonometer, what is called eye care, which is quite okay for a screening. The advantage of NCT is it probably gives you the range. You just want to know whether it's high, normal. Okay, it is probably not very accurate in higher ranges, because for a pressure of 40, it may probably take it as 42 or 46. It doesn't matter, 40 is 40, anyway you need to treat it. But in the normal range of IOP, these are very, very accurate. That is the advantage of using the screening test. Obviously, they need to be calibrated. You can have any age limit. We have an age limit of 30, above 30, we routinely screen all patients. And in patients, risk population less than 30, which I'll come to later. The high-risk children, like a lot of children, we put them on steroids for chronic allergy and things like that. And these are the patients. They may not have any symptoms attributable to glaucoma, but please check their NCT as a protocol. Tell your postgraduates to do it. And JOEG families, a lot of JOEG runs in juvenile open-angle glaucoma runs in families. So you need to actually check the family members also. So anything more than 22, perform an applanation, multiple recordings, office hour DVT, even 24-hour DVT. We have done studies where your office hour DVT of 7 a.m. to let's say 7 p.m. or 10 p.m. and a 24-hour DVT, sometimes you have lot of variations, and wherever in a particular OAG, in a IOP suspect, you are justified in probably doing a 24-hour DVT, at least an extended office hour DVT, where you add a 7 a.m. and a 10 p.m. reading into it. And you have to, all the postgraduates have to understand that they need to calibrate their fingers. They can put it on the lower lid, on the infratemporal side, and just try to create a fluctuation or press the sclera to get an idea whether the IOP is high, normal or low. Once they calibrate that, especially post-operative patients, in patients where you cannot do a contact tonometry, you can at least get an idea where the pressures are high or not, which we can actually, over a period of time, it actually makes a difference. And we do get a lot of patients where they have large cup disc ratios, and many of them actually are false alarms because they are symmetrical large cups because of a large optic disc size. So you need to check the size of the optic disc. If it is larger, then probably you are dealing with a case of a physiological large cup. If it is not larger, then probably you need to worry, especially if there's an asymmetry. And I feel more than the IOP, your disc evaluation has to be spot on. If you can pick up the disc finding, because that is the effect, not the cause. So you have to move from cause to the effect. ONH evaluation is very important. If you have a strong family history, please keep checking the members. Hypertensives who are on oral beta blockers can have erroneously low levels, high myopes, and patients on steroid eye drops and post-intravitreal injections. They may have IOP spikes like nobody's business, and people with thyroid problems. And finally, you have a patient who has a decompensation post-cataract. You may not know it is not a corneal decay, it may be actually a secondary glaucoma which you have missed. The IOP may be very high, and that could be the only reason why the cornea is still edematous. And patient with closed globe injuries, always rule out IOP elevation. It may not come at the time of the presentation, it may come after a few days later. And obviously, we are very busy with our VR surgery colleagues, because every alternate patient has to go through the glaucoma department. And finally, these investigation that we have, all the ONH imaging, OCTs and HRTs and GDX, they just have their own limitation. Clinical examination is still the king, perimetry still rules the roost, and you need to clinically correlate. So finally, if your mind is not open to it, you may miss glaucoma. Comprehensive examination is very important. Clinical findings are more important than your investigations. And obviously, you need to take the history, routine IOP examination, and a perfect and accurate disc evaluation is probably the key in not missing a glaucoma, even though you have a busy OPD. Thank you very much.
Thank you, KP. As usual, very clear, very lucid, and very useful for all the postgraduate students. Since we are a bit short of time,
no problem.
We
Thank
won't
you
have
very
much
much
of discussion.
Oh, thank you.